Hello, everyone, and Assalamu alaikum. My name is Fariz Yahya from the University of Malaya in Kuala Lumpur, Malaysia. Now, first of all, I would like to thank the organizers, especially the Pfizer team, for the invitation, and also for the rest of the staff for the hard work behind the scene as well. Thank you for inviting me today. And today I'll be talking about the role of Tofacitinib, not just on its generic, but more of the originator Tofacitinib in the management of rheumatoid arthritis. This is my disclosure statement. And this is the outline of my talk today, which will be covering on the JAK inhibitors, especially Tofacitinib, the latest rheumatoid arthritis treatment guidelines available, differences between biologics, targeted synthetic DMARDs, and also biosimilars. I'll also be talking about Tofacitinib's efficacy and its effectiveness from the various studies, and also a case study at the end. Now, I'll start by talking about JAK inhibitors in general per se. And most of us know about JAK inhibitors, and most of you as well might have already used it in your clinical practice. But let's understand a bit more detail of its mode of action. In inflammatory diseases, there are various cytokines which regulate the inflammatory response. The MAPKs are a family of serine threonine protein kinases that direct cellular responses to a variety of stimuli, such as the IL-1, TNF-alpha, and IL-6. And these actually regulate cell proliferation, the differentiation, cell survival, and apoptosis. And in this pathway, the inflammatory stimuli and stress actually activate JNK and P38 to produce inflammation. The NF-kappa B signaling cascade is triggered by toll-like receptors and inflammatory cytokines such as TNF and IL-1. And this pathway actually requires the IKK subunits or the I-kappa B kinase complexes. And these actually regulate the pathway activation. And when you have an overactivation of this actually results in inflammation. The IL-17 pathway, which we all know, is involved in the pro-inflammatory cytokines released in spondyloarthritis and psoriatic arthritis. And there are other pathways as well which are involved in inflammation, including the CAMP and the PI3K signaling cascades. And the most important one for today's session is the JAK-STAT pathway. Now, the highly conserved JAK-STAT pathway involves diverse cytokines, and it's a signaling mechanism through which the extracellular factors can control gene expression. And we know that there are 4 different JAKs available, which is the JAK1, 2, 3, and TYK2, with various different combinations of JAKs and STATs that assemble into these complex multimers. Now, the JAKs are activated by ligands and phosphorylate one another, so that creates a docking site for the STATs. The cytoplasmic STATs recruited to these sites tend to undergo phosphorylation and then what we call dimerization before the translocation to the nucleus. And therefore, the JAK-STAT signaling allows for the direct translation of an extracellular signal into the transcriptional response and then regulates the transcription of inflammatory genes. So what we have found today is that we can actually suppress the JAK-STAT pathway with the use of JAK inhibitors, such as for Tofacitinib in rheumatoid arthritis. And in rheumatoid arthritis, there are several key cytokines which are involved in the pathogenesis, and a significant number of these cytokines are also involved in the JAK pathways. So in order to inhibit these key cytokines, inhibiting the JAK pathway could actually prevent the pathological inflammatory process from happening. Therefore, what we have is Tofacitinib. So Tofacitinib is actually a pan-JAK inhibitor. So it has a greater selectivity for JAK1, JAK3, minor activity with JAK2 and TYK2. Now, when the cytokines bind to the cell surface receptors, Tofacitinib would prevent the phosphorylation and activation of JAKs. This would then prevent the STATs from docking and leads to a reduced gene transcription and cytokine production. And these so-called JAK inhibitors that we have today are also known as small molecules. But it's not just the JAK inhibitors which are known for this. We are all familiar with the other so-called small molecules, such as methotrexate and sulfasalazine and leflunomide, and these are called under the conventional synthetic DMARDs. But there is a difference. The difference is that these conventional small molecules have various mechanisms of actions, whereas the JAK inhibitors have specific targets and are therefore called targeted synthetic DMARDs. And to date, we have 3 approved targeted synthetic DMARDs in my country where I come from, and there's also another JAK inhibitor called filgotinib, which is available and approved in Europe. And with that, we now have the conventional synthetic DMARDs, we have the targeted synthetic DMARDs, and you all know there is also biologic DMARDs as part of the treatment for rheumatoid arthritis. Now, sometimes we may have too many options available, and it may make it more confusing of which one to choose from. Therefore, treatment recommendations and guidelines are mostly useful. And here I have the 2021 ACR guidelines for the treatment of rheumatoid arthritis, which they have actually issued 44 recommendations. But for today's talk, I should only highlight the 2 out of the 44 recommendations here, one of which is adding a biologic or targeted synthetic DMARDs, which is recommended over triple therapy in those patients who are on methotrexate but not at treatment target. And the other recommendation from the ACR guideline is that switching a biologic or targeted synthetic DMARD to a different class, rather than the same class for patients who are taking a biologic or targeted synthetic DMARDs, but they're not actually at treatment target. Now, if we look at the EULAR treatment recommendations for rheumatoid arthritis, this is the 2022 update, which was recently published a few weeks ago, and there were no new drug class being approved since the 2019 update. And if we look at this recommendations from EULAR, the initial phase of the EULAR guidelines remain unchanged, which is to start methotrexate, or leflunomide or sulfasalazine for those unable to tolerate methotrexate. And patients who do not respond and with poor prognostic factors present, they should be added a biologic or a JAK inhibitor after risk assessment. Now, one of the focus of the task force for this 2022 update was the safety aspects of JAK inhibitors, for which they actually recommend doing a risk assessment when starting a JAK inhibitor. So things like age over 65 years, patients who have cardiovascular risk factors, malignancy risk factors, or having risk factors for thromboembolism should also be assessed. But nevertheless, the use of JAK inhibitors still remain as part of the treatment recommendations for RA. And for those patients who fail the initial biologic or JAK inhibitor, it's still recommended to change to a different biologic or JAK inhibitors. But what about the main differences between the targeted synthetic DMARDs and biologics, and also even the biosimilars? Now, JAK inhibitors are small molecules that target intracellular enzymes with the different cytokine signal through different JAKs, and it basically affects multiple cytokine signaling pathways. Whereas for biologics, they are relatively large and complex molecules in which no exact biologic is identical to another biologic. And biologics also work outside of the cell, and also it's highly specific. So there are significant differences between these 2 therapies, which I think is quite clear. And on biosimilars, on the other hand, so biosimilars were initially developed with the goal to reduce costs and to give more access to biologic therapy. So they would need to undergo rigorous evaluation in comparison to the reference biologic. And this actually includes having the same effectiveness, safety, and quality, having no clinical meaningful differences, and also demonstrating similarity to the reference biologic drug. And since biologics itself are really complex proteins, the production of a biosimilar is not the same as a non-biologic generic drug. And this includes the generics for a JAK inhibitor. And when we compare the cost, the development of a biosimilar is way higher than the development of a non-biologic generic drug. And if you look at this diagram, it actually shows a hypothetical comparison of drug development pathways. And as you can see, either for a new biologic medicine, a biosimilar, or for a small molecule generic. And the development cost and time for a biologic are much more than to develop a small molecule generic. Now, although potentially shorter than the development process for reference biologics, the development of biosimilars is quite rigorous. It involves time, a lot of investment, even up to 8 years, with costs of around 83 to 165 million euros. Whereas for small molecule generics, they may only need about possibly 4 million euros and take approximately about 2 years to develop. These generic medications would be less expensive than the equivalent originator medicine because it's not necessary for these generic medicine manufacturers to repeat the discovery. They don't need to repeat clinical or even the clinical studies. But nevertheless, with the generics, relatively simple bioequivalence studies are being acceptable in their place, and the bioequivalence parameters and the legal requirements for generic medication may not be the same in all countries. So it may not be as stringent as in the United States or in Europe. And if we look at the clinical studies for biologics and JAK inhibitors, now this real-world population study was composed of over 8,000 propensity score matched seropositive RA patients who were prescribed biologics or tofacitinib. And compared to first etanercept users, patients with first-line choice of advanced therapy by using tofacitinib, tocilizumab, or abatacept had lower risk of drug failure. And second-line choice of tofacitinib or tocilizumab was also associated with lower drug failure risk compared to second-line etanercept users. And the same goes when used as third line. And as we can see here, the use of tofacitinib, either as first line, second line, or even third line, have lower risk of patients discontinuing treatment when compared to etanercept. And this meta-analysis, which you can see here, actually involved 50 RCTs or randomized control trials, and it involved over 24,000 rheumatoid arthritis patients, where you can see in the forest plot that the green diamond marks actually represent the overall effects. Now, what this study found was that JAK inhibitors proved to be statistically superior to biologics in the response rate, in which it's more likely to improve with a JAK inhibitor within 6 months based on the ACR 20, 50, and 70 criteria, and also under DAS28 CRP responses. And it's not just the ACR 20, 50, 70, and DAS28. If we look at the forest plot in this diagram, the green diamond markers are in favor of using JAK inhibitors. And as you can see here again, the JAK inhibitors were able to decrease pain. I was able to reach significantly better results in swollen joint count and tender joint count, and also managed to reduce CRP at a greater extent than biologics. So there may be more benefits of using JAK inhibitors, and the evidence from clinical trials for JAK inhibitors were able to support that, especially for tofacitinib, as tofacitinib was actually approved as the first JAK inhibitor for rheumatoid arthritis way back in about 2012 from the FDA. And the phase 3 clinical trials from its drug development program demonstrated robust and rapid effects of JAK inhibitors compared with placebo in RA patients who were methotrexate naive or those who were inadequate responders to methotrexate or to biologics. And if we look specifically at tofacitinib and its clinical development program in rheumatoid arthritis, the phase 3 clinical trial started about 15 years ago, with the most recent trial completed, which was the oral surveillance study. But nevertheless, tofacitinib has now been approved and included in the 2 major treatment guidelines for rheumatoid arthritis, as I mentioned earlier, both ACR and the EULAR recommendations. And if we look at the details of these clinical trials, the use of tofacitinib, whether as monotherapy or in combination with methotrexate, was able to give higher proportion of patients to achieve that ACR 20, 50, and 70 responses compared to placebo. And these results actually go across the board, including for the oral solo study, which was for tofacitinib monotherapy, the oral SYNC study, oral SCAN, oral standard, and oral STEP studies. And for these 5 clinical trials, tofacitinib also showed efficacy in improving physical function by the measurements of the HAQ-DI scores compared to placebo. Tofacitinib also showed, if you can see here, numerical similar efficacy to adalimumab in the oral standard study. Now, what about radiographic progression? There are also data on radiographic progression. If you look at the diagram on the left, the mean change from baseline for the sharp under high D scores was statistically significant for tofacitinib for both 10 milligrams, and a reducing trend, but not significant with the 5 milligram dose. The other two figures actually show erosions and joint space narrowing. Now, although there were no significant changes for erosion scoring from baseline, there was significant reduction in the joint space narrowing scores for both doses of tofacitinib. And if we look at the oral sequel, which is a long-term extension study. Now, the oral sequel was actually a global multi-center open-label long-term extension study, which primarily assessed the long-term safety and tolerability of tofacitinib 5 and 10 milligrams doses. And as you can see here, both charts are for the 5 milligram dose, in which after 8 years, tofacitinib 5 milligrams was able to maintain ACR response and also physical function as measured by the HAQ-DI scores. Now, this study actually demonstrates that tofacitinib was able to show sustained efficacy for up to 8 years. But the primary aim of this oral sequel study was actually to assess long-term safety and tolerability of tofacitinib. And between 2007 and 2016, there were almost 4,500 patients enrolled for the study. The total tofacitinib exposure was over 16,000 patient years, and the safety data were reported up to 9.5 years. I know this is a busy chart, but if you look at the events for the columns for all patients on tofacitinib with combination therapy and patients on tofacitinib monotherapy, the safety profile remained consistent over 9.5 years. And in essence, both tofacitinib 5 milligrams and 10 milligram doses demonstrated a consistent safety profile as monotherapy or as combination therapy. Now, let's take a look at the real-world evidence for tofacitinib. This was taken from the Corona registry from North America, and now this registry has been renamed as COEVITAS. What this registry study assessed was comparing the effectiveness of TNF inhibitors with Xeljanz, or the originator tofacitinib, in patients from the United States. Now, the duration for the study was for 6 months. The number of patients who were on Xeljanz was 244 in total, whereas there were over 5,000 patients on TNF inhibitors. But bear in mind that the number of patients who were on TNF inhibitors were more because TNF inhibitors were already approved long before tofacitinib, and that's why you see more patients on the TNF inhibitors. And when we look at the effectiveness of Xeljanz from the registry, based on the odds ratio, there were no differences in treatment response whether Xeljanz was used as combination therapy or monotherapy. And there were also no differences in treatment response if we compare TNF inhibitor combination therapy to Xeljanz monotherapy or Xeljanz combination therapy, as patients were likely to achieve CDAI low disease activity or remission, or the ACR 20 or ACR 50 for both of these treatments. And if we look at another registry, and this is actually coming from the Swiss SCQM registry, where the study objectives were assessing effectiveness and comparing drug maintenance, including for Xeljanz, in a Swiss cohort of RA patients. This registry actually involved about 2,600 patients with over 790 patients on Xeljanz, over 1,800 patients on TNF inhibitors, and the remaining 1,338 patients were on biologic DMARDs with other mode of action, which is different to the TNF inhibitors. Now, what this registry actually found was that the overall drug maintenance for Xeljanz was similar to the biologic drugs with other modes of actions. But as you can see from the chart on the right, Xeljanz, either as combination therapy or monotherapy in the red and orange lines, had the longest drug survival. And looking at the 0.5 probability to stay on treatment, this indicates that 50% of patients were more likely to remain on Xeljanz at around 2 years, in which the rates were higher than the biologics, either whether it's TNF inhibitors or biologics with other modes of action. And now I'll be showing a case study of a patient who received originator tofacitinib Where I come from, we only have Xeljanz. We don't really have generics for Tofacitinib. And this case is a 57-year-old Chinese lady whom I saw just before the COVID pandemic began. She has underlying hypertension and was initially diagnosed and treated at a private medical center nearby around Kuala Lumpur. But due to logistics and she was having increasing financial issues, her care was then transferred to our center. She was on methotrexate, leflunomide, and hydroxychloroquine. She was unable to tolerate sulfasalazine and also unable to tolerate higher doses of methotrexate. She had high inflammatory markers, even though with the previous results from her old center as well. Now, I talked to her, we had a really long discussion, and she finally agreed that we should start her on a biologic or biosimilar. And she was actually started on infliximab biosimilar infusion. Now, this patient was a self-paying patient, and as you know, that expectations for improvement was high, especially if you need to pay a reasonably higher amount for the cost of medication. And unfortunately, she didn't have or feel any improvement in her symptoms with the infliximab biosimilar. She didn't have any reduction in her ESR or CRP even after 3 months. And we discussed again, and she actually was switched to Xeljanz or Tofacitinib. And she had good improvement even at 6 weeks of Xeljanz. I met her at 6 weeks after treatment. She had significant improvement in her DAS28 score. Her joint symptoms actually completely resolved, and she remained on Xeljanz even at her most recent clinic visit in November last year. And in summary for this patient is that despite the persistent high inflammatory markers, failing conventional synthetic DMARDs, she needed to self-fund her treatment. She did fail infliximab biosimilar, but the choice of using Tofacitinib was probably the best choice for her. And in the real world, not all patients that we see in clinical practice would actually stop and tell us that they are not satisfied with treatment. They won't tell us that their treatment are not working. Sometimes we have to find out from ask these patients more detailed questions. And this study found that 74% of RA patients remain unsatisfied with their treatment, including patients who are on biologics. And it's that presence of fatigue, that sleep disturbances and pain, which were not adequately controlled or addressed by their treatment, this gave them that dissatisfaction. And if we look just around our neighboring Asia country itself, sometimes the routes of medications taken would be important, as evidenced from this study from Lebanon. And this study involved around 700 patients. It found that almost 64% of RA patients prefer the oral route for medications. And for those patients who were already on oral treatment, they were 9 times more likely to continue with the oral administration rather than getting treated by IV infusions. Now, therefore, the right medication is important, and the use of JAK inhibitor is something we should consider in our patients, especially with previous conventional and synthetic DMARD failure or biologics failure. But we must not forget to assess for cardiovascular and malignancy risk, especially in the elderly RA population when we are choosing JAK inhibitors. Now, nevertheless, a shared decision, maintaining good communication, these are key points that we should adapt in our daily clinical practice. And finally, the ACR and EULA guidelines both have incorporated the use of JAK inhibitors in rheumatoid arthritis treatment. JAK inhibitors have also shown efficacy, effectiveness, and relatively good safety profile. And also, Tofacitinib is able to improve patient symptoms and function with the oral formulation, where JAK inhibitors may seem to be more appealing treatment option, especially as an oral route medication for patients. And with that, thank you very much.